My name is Koen Vandelannoote. I'm not a New Zealander, but a Belgian computational microbiologist. And I work for the Tasmanian Health Service at the Royal Hobart Hospital. However, the work that I'll be presenting on today is work that was carried out at the Stenair laboratory, where I worked in the capacity of a postdoctoral researcher in the University of Melbourne at the Doherty Institute. I published this work, I think, about 2 years ago. The last 4 years I've spent working and living in Cambodia at the Cambodian Pasteur Institute. So I never really had the opportunity to present on this. I just wanted to say thank you to Nick for the opportunity to actually present some of this data. So today I'm going to talk about how we can use fecal surveys of possums to predict Buruli ulcer outbreaks in humans. But before I delve into that, I think it should be, should be a bit of time to just introduce Buruli ulcer for the uninitiated. So Buruli ulcer is a neglected tropical disease that is caused when an environmental bacterium is introduced into the subcutaneous tissues of a species. And it doesn't matter how that happens. That could be a mosquito bite, a hypodermic needle. But when Mycobacterium ulcerans finds itself in the subcutaneous tissues, what ends up happening, it produces a endotoxin that is both cytotoxic and analgesic. So it'll break down the subcutaneous tissues while creating slowly developing wounds that are relatively painless. So patients typically don't present quickly to their GPs. And as a result, we get that a lot of the skin gets destroyed before people actually present. And that's unfortunate because undermined skin leads to deformities, leads to the requirement of skin grafting and what. And we have perfect antibiotics to treat Buruli ulcer disease. So just an oral regimen of rifampicin and clarithromycin can treat Buruli ulcer in the early stages without requiring plastic surgery. We also have great molecular biology tools at our disposition to do the molecular diagnosis and at the same time to look for M. ulcerans in the environment. So there's a qPCR that has more than 200 copies, that targets more than 200 copies of IS2404. And when we run that assay, we can very sensitively and specifically detect M. ulcerans both in patient samples and in the environment. And I should also say that Buruli ulcer is a really long incubation time. Similar to a lot of non-tuberculous mycobacteria, it has a really slow replication time, and that leads to a long incubation time. So on average, after a moment of exposure, there is a 4.8 months before the onset of disease, and that'll become very relevant later on. So very quickly, you can see Buruli ulcer in the world. So you can see the majority of the countries that are actually have cases, they're found in West and Central Africa, where I previously did the majority of my work on Buruli ulcer. However, we do see that there's two temperate regions where we find Buruli ulcer. That's the south of Australia and the south of Victoria. We also find it a little bit in Japan. So you can see that there's a couple of hotspots in Australia that are indicated there. The majority of them are actually more or less historic. We do notice, though, that the majority of the cases are actually coming from the south of Victoria, specifically the Bellarine and the Mornington Peninsula and the city of Geelong. So you can see below there the epidemic curve, where you can see the amount of cases that have been notified to Department of Health of Victoria. And you can see that since 2011, there's been an increase in cases and hasn't really ever gone down apart from the COVID pandemic. Now, I should also note that the majority of these cases are contracted during the later months of summer. This is like a destination where a lot of holiday goers go towards. I should say a couple quick words about the transmission as well. So let me take you back to before 2007. We didn't really know how people got Buruli ulcer disease. So all we knew was that humans couldn't infect humans. So it was a non-communicable disease. But then in 2007, people were start doing these environmental surveys, and they found here and there some positive samples in the environment, but always low positives and nothing really too concrete. But in 2007, Professor Johnson and his team, they detected that in fact mosquitoes were 1% positives in environments where there were Buruli ulcer patients, and specifically the species Aedes nondescriptus kept coming back as being positive. Now, another big milestone came when the same group of researchers, complemented by Janet Five and Timothy Stenair, when they also started sampling, pellets of feces from native possum species, the ringtail and the brushtail, and they just found the mother loads of Mycobacterium ulcerans DNA. So they found like 5 orders of magnitude higher concentrations in those fecal pellets. So that indicated that, in fact, the possum was a likely reservoir, and that kind of work was then complemented by veterinary scientists that looked at these possums after trapping them, and they noticed indeed that they actually also got the disease. So they got the same lesions, they got the same ulcers, and they were in fact a reservoir. But you can put all of this together, but I just saw the Barnett criteria and Koch's postulums before, so that doesn't mean that we see a reservoir, that we see a potential likely vector. That automatically means that is how humans are infected. So luckily, there was this recent landmark paper published in 2024, and that really showed the directionality. I don't really have the time to delve into it, but essentially, when possums, when they produce these fecal pellets, if they fall into stagnant water bodies, what can happen is that these mosquitoes, as they develop, they're covered in ulcerans, and if they then, do a blood meal, take a blood meal on a human, you'll get a potential Buruli ulcer growing. So since we know so much now about the transmission, we thought we'd have a go at using this knowledge to actually predict cases in the future. So this was very much inspired by other zoonotic pathogen surveillance work, where there were sentinel surveys that are typically done with rabies, West Nile virus, and on the bacteria side with Lyme disease. And what typically is being done is, you collect a couple samples, and with that, you try to predict human cases in the future. Now, it's a very easy analyte to collect. You just, walk along the streets and you collect possum poop. And if you're in the Mornington Peninsula, you find poop everywhere. Like, it's just remarkable once you have an eye for it. It's also very easy and pretty cheap to do. And you don't really need to train, people a whole lot to collect poop on the roadside. So, but we did realize if we're going to sample the entire Mornington Peninsula, we're going to use technology to our advantage to actually achieve this. So to do that, we did a couple of things. Like for example, I developed an application that ran on Android devices and that allowed us to go completely paperless. In the initial rounds of investigations, we used paper, and that just slowed us down, and we had to collect thousands of sites. So we use the ODK sample toolkit. So imagine I'm a surveyor, I arrive at a particular location, I open up the app, I collect the GPS location with the GPS module, I select my name, I select the time, and then I have 5 minutes to start looking for possum feces. And if I don't find any possum species at that spot within 5 minutes, the form is ended and I move to the next spot. If I do find possum species, then I collect it with pre-labeled bags that have barcodes on them, use the phone cameras to scan the barcode, and then I take a picture of the sampling site. And then based on the scat morphology, I predict the species of the animal. That is like the hardest thing to do, but you can see like on the picture over there, there's a clear difference between ringtail and brushtail. Sometimes if it's broken down, it's a bit harder, but anyway, we take a picture of the sampling site and we're done. Now, there's another thing that we did. We also wanted to, make sure that whenever we collected possum feces, that we did it 200 meters apart. So these possums, they have a home range of about 100 meters, and we didn't want to resample the same possum. So that's why we developed these beepers that had a GPS module inside of them, soldered to an Arduino microcontroller and a lithium-ion battery. And you would hit it once you're done sampling, and then you'd start walking or cycling or driving. And then after a while, it'll go beep, 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 beep. And at the beep sound, that meant that you're 200 meters apart as the crow flies. So unfortunately, when you charge them, they did have a tendency of catching fire because there's lithium-ion batteries in them, but small detail. So anyway, here you can see like our sampling efforts, like you see at the bottom left, the Mornington Peninsula, where that we covered 2 times. So it's a massive area, it's 350 square kilometers. We visited 2,402 locations, and in the majority of these locations, we actually found possum poop. And to the right, you can see the area of Geelong. And in the area of Geelong, I'll come back to this later, but you can see that in both areas, we actually looked at the residential areas, pretty much all the residential areas that there are. Now, of those 2,402 locations, In them, we found on 2,282 of these, we found possum poo. And 13.6% of it was IS2404 positive, meaning that there's Mycobacterium ulcerans DNA inside of it. And here you can see the mycobacterial loads in all the positive samples that are in like bins in sampling season or in species. So during the summer months, we saw that the mycobacterial load in the pellets was slightly higher than in winter. It wasn't as extreme as we expected, actually. We didn't see a difference between the species. But now we get to the interesting bit. So we did these surveys, and then later we got the data from the Victorian Department of Health that showed all the notified cases. And then we selected the notified cases that had an exposure interval that overlapped with our sampling surveys. So we only looked at the ones that could have been infected during the period of the surveys that lived in that specific area. And by doing that, we get this. Now, there's a lot going on in this figure, so allow me to take you it, one step at a time. So in yellow, you can see the Mornington Peninsula. It's separated by mesh blocks, which is the smallest statistical unit that the ABS can provide. We also got our anonymized data from notified cases from the Victorian Department of Health, anonymized by mesh blocks. So that's why you see these breakups. And then you can see like the little dots everywhere. So let's start with the fecal survey itself. I'm not sure if you can see my mouse pointer, but all right, we'll just do it like that. So if you got a dot that is black, that is filled in black as well, that means that we've been to that site and we didn't find any feces. I mentioned before, there's not a lot of these spots. We really have to go looking for them. However, when you see another dot that's filled with white, it means that we did find feces, but it was IS2404 negative. There was no M. ulcerans DNA inside. Then when you take the spots that are either dark purple or light pink, those are the locations where you actually found IS2404 positive feces samples. And the darker the purple they are, the higher concentration of M. ulcerans they were. So you can see in the area around Sorrento, that there we found a lot of possum feces with super high concentration of Mycobacterium ulcerans. Now, separate from that, you can see that the mesh blocks, if they're yellow, that means there weren't any notified cases. If they're colored in like this gradient of blue, it means that we found cases that were linked to that specific mesh block. So in rye, for example, it's unfortunately that I don't have a pointer, but here you can see, for example, that there were 4 cases found in this one mesh block, while in others we just had 1. So then you can ask yourself, okay, like, is this random, or is there actually like specific regions where you see a higher risk of contracting Buruli ulcer as a human from a background population? And then, it turns out that yes, you see the spatial scan statistics there in blue, those big circles. So you see areas where it's more likely to contract Buruli ulcer disease relative to others. And similarly, we got the spatial scan statistics from IS2404 positive feces. So we saw that as well. Yes, indeed, it turns out that, there's areas where you can find a lot more IS2404 positive species. And what was cool is that they're actually non-random. They're co-correlated. So we see clustering of M. ulcerans positive possum excreta and human BU cases. So that was already a pretty impressive result, but the scale is still pretty massive. You got these big circles. So imagine if you have to send out a letter, hey, you know what, wear mosquito repellent, or get rid of the stagnant water in your garden to prevent mosquitoes from breathing in there. So we wanted to do something better, and that's why we used a machine learning approach. I know it's something of a buzzword right now. Was as well 5 years ago, but anyway, it really worked. We used machine learning, and we used the Mornington Peninsula outbreak information together with our fecal survey to predict mesh blocks, their likelihood of finding new cases of human Buruli ulcer in them. So we trained this data with the Mornington Peninsula data, and then we applied it to an unseen data set that was actually collected by a collaborator, Kim Basil, that works in Geelong. So she did exactly the same thing during COVID times. And, it's a fairly similar survey. I'm not going to go into details of it. But in the end, what we ended up seeing is that we could predict fairly well, like mesh blocks, with a likelihood of finding cases of human Buruli ulcer in there. So the metric that is typically used in these kind of inferences is the area under the curve, and we scored 0.75 for the preciseness of our model. We compared it with a null model where we didn't look at our fecal data and where we just looked at the incidence that was reported to the Victorian Department of Health the year before. And that just showed that, you know, even picking mesh blocks randomly would give a similar result. So there was no information in there. But in our model, at least, you know, it goes from 0.5 all the way to 1. We ended up getting a 0.75. So it's not excellent. It's still pretty good. So in conclusion, just two little statements here because I'm probably already out of time. But our study highlights, you know, that Buruli ulcer is indeed a One Health kind of issue, and that there's a quantitative relationship between possum excreta shedding and humans developing Buruli ulcer. And our excreta survey also showed that we can use these models to target responses to Buruli ulcer at the mesh block level. So with that, I'd just like to thank you for your attention. And this study has been published. So if you want to learn a little bit more, this is the reference. And you also see listed here all the people that worked on it. So thank you so much.